Chapter 37, Hazardous Materials, Multiple Casualty Incidents, and Incident Management. So we'll talk about your role as an EMT on a hazmat incident, how we know if we're dealing with a multiple casualty incident, and what your role is on an MCI. We'll talk very briefly about ICS, or the Incident Command System. We'll talk about triage and the logistics of an MCI incident. And we'll also talk briefly about psychological aspects of MCIs. So, hazardous materials. So a hazardous material is just what it sounds like, a substance that poses some unreasonable risk to health. And this is the Department of Transportation's definition. So they talk about it being transported, but it can also be obviously stored in a facility and then leak or something and cause an incident. So there is hazmat or hazardous materials training available. These are the levels. So the awareness level basically is you knowing enough to not injure yourself or become a victim, and start to be able to identify materials and create safe zones. At the operations level, you're starting to get into some of the technical equipment and operations that are in the cold zone and how to decontaminate people. When we start talking about the technician and specialist levels, then these are the folks that are going to get into the suits and actually go into the warm or hot zones to try and deal with a hazardous material. So your job as an EMT on the hazmat incident is, one, to recognize it and not get your ambulance contaminated with whatever hazardous material by loading up contaminated patients into it, that kind of thing. So you should also try and control the scene if you're the first unit responding, or help control the scene if there's another person that's already IC there. If no one has done so, you should establish a danger zone and a safe zone, and then we can attempt to identify the substance that we're dealing with. So how do we do that? We look for signs, labels, placards, and from far away. So binoculars is a good option. We should have binoculars in each of our ambulances. And we're going to look for NFPA placards, or if it's in a vehicle that's involved, then look for the DOT labels. If we're responding to someplace else, like up on campus perhaps, then we'll have hopefully MSDS sheets available. Other sources of information can be bills of lading, invoices, manifests, and then hopefully somebody that was involved in the incident knows what the substance is. So we can look up the substance in this ERG, that's the orange book there, the Emergency Response Guidebook. And then we can also get some information from dispatch, and if there are any hazmat experts available. So we can call one of these numbers to get other advice about what to do to clean up the spill. And that's going to really be, again, people that have hazmat operations and technician level training that are going to be dealing with the spill. Our job as EMTs is to deal with patients after they are decontaminated. So when we're dealing with a hazmat incident, we're going to establish these different zones. So the hot zone is where the material actually is, and if you enter that area, there's a danger of you becoming contaminated. The warm zone is an area immediately adjacent to that. The size of that is dependent on the material and how large or how likely it is for that material to spread quickly. And then the cold zone is an area outside the warm zone. And this is where you're going to be operating, and this is where equipment and rescuers are staged. So here's a graphic showing these different things. The hot zone, decontamination occurs in the warm zone here, and then we'll deal with patients after they get through decontamination and out here into the clean area. If there is any wind, you want the wind to be blowing contaminants and stuff back into your hot zone away from you. So that's the wind direction thing there. So again, the rehab operations are located in the cold zone and hopefully protected from weather. This can be temporary structures that we set up. It can be another building, another house, something to that effect, and hopefully large enough to accommodate multiple rescue crews, and along some kind of road that's easily accessible to ambulances. So again, we decontaminate in the warm zone and then treat those patients out in the cold zone. So when people are decontaminated, that's just removing whatever the hazardous material is from them. That can be in a couple of phases. So a gross decontamination where they're basically sprayed with water, and then a secondary decontamination where you get more thorough soap brushes, that kind of thing. So here's decontamination pictures here. And again, depending on what the material is, will dictate which specific steps of this decontamination process are necessary. So these are some different ways that you can decontaminate people. So you can just spray water off, dilute whatever the whatever the hazardous material is. You can try and absorb it with something. You can introduce some other chemical that reacts with it and makes it nullified. Lots of different things. So most of the time, victims are probably not going to be wearing PPE, but you may have to decontaminate, or you will have to decontaminate the responders that go in to deal with the hazardous material wearing appropriate PPE. Okay, so we're going to switch gears a little bit to multiple casualty incidents. So MCIs are essentially when the number of patients exceeds the number of EMTs. So we try and plan for MCIs as much as we can. We typically do MCI drills approximately every other year to try and practice coordinating all of our local EMS units and Gritman. And so these plans are put into place, and it's kind of a step-by-step, here's what to do if this happens, here's what to do if that happens, that kind of thing. And like I said, we try and practice these things about every other year. When we're dealing with an MCI, and in particular any incident, we will use what's called the incident command system. And so this is a framework for organizing and providing consistent roles and terminology for responders from different agencies so we can all work together and accomplish something. But it also, like I said, we use this on any incident, and so we'll use this just within the department too. So every incident has an incident commander, an IC, and then depending on the size of the incident. All of these different categories or areas are also filled. So operations, planning, logistics, and finance. So we operate under operations typically as EMS providers. Somebody may be working out of a mobile command center, and all these other things are kind of part of the structure. Triage. So when we have more patients than we have EMTs, somebody's going to get treated first and somebody's going to get treated last. So we don't have enough people to treat everybody all at once. And so triage is a French word. It just means sort. And that's exactly what we're going to do. We're going to sort the people that need treatment first from those that can either not get treated or wait to be treated last. So we put people into these 4 categories, 1, 2, 3, 4, or red, yellow, green, black. So the folks in category 1, the red category, they get treatment first as they have treatable, life-threatening illnesses or injuries. The folks in the second category have serious injuries that need treatment, but they're probably not going to die immediately or soon from that injury. Priority 3 folks are what's called walking wounded, so they may have sustained some injuries, but are generally okay and may not need to be transported to the hospital at all. And then there's your priority 4 folks, are the black-coated folks that are fatally injured from the incident. And those folks are not going to get treatment or transport and by EMS. So the way we sort people is this START triage system. And so START is an acronym, stands for Simple Triage and Rapid Treatment. And the idea is just a very simple system that can be applied quickly. And so what we are going to look at our patient, we're not going to do a full assessment on each patient. We're going to look at their respiration, their pulse, and their mental status, or RPM. So the procedure for START triage basically goes like this. Somebody rounds up everybody that's able to walk. If they can walk from the scene over to a staging area or treatment area, then we're going to initially at least categorize those people as green because they're able to walk under their own power and follow directions. So that gets all of our green-coded people kind of out of our scene and out of our way. Next, we're going to go one by one and check folks. So we're going to check for respirations. See if they're breathing. If they're breathing and they're hyperventilating, so greater than 30 a minute, then we're going to code them red and move on to the next person. If they're breathing and it's a more normal rate, less than 30, we're going to check their pulse. So if they're breathing but no pulse, then we're going to reposition their airway and recheck respirations. If they're breathing, we're going to check a pulse. If they're not breathing, then we're going to position their airway with a head tilt, chin lift, and then recheck respirations. If opening their airway doesn't get them to start breathing, then we're going to code them black. So we're not going to start CPR on these folks in an MCI situation. So when we're checking their pulse, we're going to feel if they have a radial pulse. We're going to see if their skin tone is normal. We're going to check cap refill. This is on adults as well as kids. And we're going to check just to see if they have decent perfusion. And if they seem to be okay with the pulse and perfusion, then we're going to go ahead and move down the list and check their mental status. If they don't have a pulse, so they are breathing but no pulse, then they're going to be priority 1. And this is probably just that we can't detect a pulse, not that they're breathing and don't have a pulse. That's not a typical way you find the patient. So after we check pulse, we're going to check mental status. If they are otherwise alert and functioning okay, then they're going to be coded yellow. If they have some kind of altered mental status, confused and can't follow simple commands, then they're going to be a priority 1 or red. So here's kind of a different way to view this flow chart, treatment chart. So first get everybody walking wounded out, those are your green. Anybody that's not breathing after a head tilt chin lift is coded deceased. And then we go through the criteria for the red coded folks. So if they have any kind of altered mental status or unconscious, they get coded red. Respirations over 30, they get coded red. Signs of poor perfusion, so no radial pulse or poor cap refill, then those folks are coded red. When we're looking for perfusion, we're going to control any bleeding that we might find immediately, so that's not something we wait to treat, just because it's easy to control bleeding pretty quickly, and you can have somebody next to the patient or the patient themselves hold pressure with a bandage. If they don't meet any of the yellow or the red criteria, then they get coded yellow, and they're delayed. Here's yet another version of this flow chart here. I think the one on the previous slide is the more useful way to do it, though. So after we triage patients, then we're going to start going through and treating them. So first we're going to treat the patients that are coded as red and transport them. And as we get more resources in, eventually we're going to have enough resources where we can treat and transport everybody that needs treated and transported. So it's really important to figure out where to transport people to. So Gritman and Pullman hospitals are going to have some limited capability to take a lot of critically injured patients. So we're often going to be transporting patients out to Lewiston, to St. Joseph Regional Medical Center, or north to Spokane and or Coeur d'Alene. MCIs are in general kind of intense, and people are going to be freaking out to some extent. And so the more you can be calm and cool operator yourself, the better it's going to be for you and for the people involved in the incident.